let's get this party started. My name is Sharon Meieran. I know so many of you here, and I use she, her pronouns. I am an emergency physician and a very proud member of the OMA. And I'm also a Multnomah County Commissioner. We have districts in Multnomah County. I represent District 1, which is mostly the West County and inner Southeast. And my topic today is harm reduction for those living unhoused, and what is a path forward. And I'm co-hosting. Bryce, would you like to introduce yourself?
Yes, thank you, Dr. Meieran. My name is Bryce. I'm a third-year medical student at Western University of Health Sciences, Comp Northwest, and I'll be your moderator for this breakout session. We are super fortunate to have Multnomah County Commissioner Sharon Meieran here, who's an emergency room physician in Portland, to talk to us about harm reduction for those living unhoused and the path forward. She spoke this past spring to the OMA student section on this topic as well, and we had a great discussion, and we're very happy to have her back to speak on this important topic. Throughout the presentation, if you have any questions or any comments, please feel free to put those into the chat, and we'll try to answer as many of those as possible at the end of the presentation. And so with that, I will turn it over to Dr. Meieran.
Thank you. All right, Brian, next slide, please. I have no conflict of interest. Yes. So we have, three main objectives today, and those are to understand some of the root causes for and types of homelessness. There's a lot of terms bandied about, and it'd be great to get those straight. And there we go. And some other objectives. So in terms of broadly conceptualizing homelessness, really there are truly as many reasons for homelessness as there are people experiencing it. And for the purpose of conceptualizing the system, however, it's helpful to consider how some broad categories of people experience homelessness. And the broadest conceptualization, the broadest reason that people become homeless, people do not have enough income to meet their housing cost burden. And we talk about transitional or episodic houselessness or homelessness, and that is people experiencing a transient period of homelessness that's often due to a life event, something, and as we often see, a precipitating medical event or bill, and people can't sustain their housing. Chronic homelessness refers to people having both a serious underlying disability, often behavioral health, so a mental health issue that is severe, and also multiple episodes of homelessness and or homelessness for over a year. So all of this can be compounded by mental illness, substance use, and I see a note in the chat, many children as well, and the fastest growing segment of the homeless population, seniors, which is, I'll get to in a little bit. But this can be compounded by mental illness, substance use disorder, disabilities, domestic violence, involvement with our justice system. And so people who may be transitionally housed, who may have become homeless due to a life event, can sort of fall into the second category as they experience the hardship and trauma of living on the street. Next slide, please. And so when we talk about that discrepancy between people's income and what they pay for housing, we can see some of the problems illustrated here on this slide. And generally, And the general rule is that people should spend about 30% of their monthly income on housing. But when you look at the numbers, when you look at SSI monthly income, that's $771. You would have to spend all of that to live in a single resident occupancy room, 100% of your income. A studio, you'd have to, spend way more. The rents right now, and these numbers are outdated, but the rents right now, particularly in the Portland metro area, are out of reach for so many people. Next. And I really love this graphic because it's, the game of life that I loved to play as a kid, where everything kind of worked out and you can get to the end and go through all these different life events. When you go through this game of homelessness, you can't win. There is no winning here. You are losing no matter where you end up, because so many life events and emergencies will push you out of housing. So next slide. And so you think about, what strategies do we have to address homelessness when we think, broadly, and this is all aspects of homelessness. So generally, we have three pillars. I'll describe them. So the best is prevention. That ideally we prevent people from falling into homelessness in the first place, and we support them enough so that they do not have to experience living on the street. Their kids will never know that they were on the brink of homelessness, that they can stay in school. And there are some strategies for that, particularly long-term rent assistance, emergency utility payments, things of that nature. Best approach, most effective, etc. If people do become houseless, then if they're living outside, we want to keep people safe. So we have shelter, and traditionally that has been a brief stay. It is considered transitional and mostly as a service connection. So get people connected to services they need, supports, and get them into permanent housing. And then permanent housing is, I think we've often heard it said that, the solution to homelessness is housing. So there are different of course, it's not as simple as that, or else we would have solved this problem. But in terms of the chronically homeless population, so people that have those severe disabilities and may have been homeless for a very long time and cycle through different systems, supportive housing is the best long-term solution. There have been studies. This is housing that is, first of all, deeply affordable. And it also has intensive and coordinated wraparound services. Because if you just take someone who's living outside who may have a severe mental health condition and you put them in an apartment, they're not going to be able to sustain that. Similarly, if you just provide services to people living outside, but they don't have the place to go to their appointments, store their medications, address some of those issues, they're not going to be able to sustain the services. You need both completely integrated. And that has been shown to be the most cost-effective and effective solution for people living who are chronically homeless. And when a lot of people think about homelessness, they think about what we see outside in our communities, on our streets, around our parks, in some areas that are off the beaten path or on the beaten path in many instances. And that is the unsheltered population. They're by and large chronically homeless. And at our last point in time count, there were about 2,000 people that were living unsheltered on the streets of Portland. So every 2 years, HUD requires that states and jurisdictions do a homeless point in time count. This is a snapshot. You get an army of volunteers and other service providers. You go out, and on one day, and it's been every 2 years, You try to find everyone you can who's living outside. They also count people living in shelters, get some basic information and count them. And as medical providers here, you can tell that that is a deeply imperfect system of understanding who people are, of counting. It's inaccurate. And this count in particular was almost 3 years ago now. So you can take a guess whether that number has increased or decreased. During COVID, some of the estimates that I've seen are that the unsheltered population is now around the 8,000 people level. So this is what we are facing, and this is what we are seeing. So next slide, please. We are talking about inequities in this conference, or equity, hopefully getting to a place of equity and inclusion. But as with all healthcare disparities, with so many of the elements, we are seeing the disproportionate impact on people of color, on people who are immigrants and refugees in our community. There are substantial racial inequities that contribute to a disproportionate number of people of color being homeless. And this has to do with centuries of structural and systemic racism that we see. So we see housing as a primary mechanism for building wealth. And what we see is that, people of color are not owning homes. They've been systematically prevented from building that kind of generational wealth because of ongoing discriminatory housing policies, for example, such as redlining, seen it with predatory lending, had segregated neighborhoods. And so that is a huge contributing factor just structurally. In addition, people of color are more likely to have underlying serious physical disabilities, and that's due to the healthcare issues that we've talked about and we continue to talk about in this conference. But it is really a lack of access to healthcare and other services. And even if they have access, they have disproportionately poorer care. And then with COVID, everything has been exacerbated. So it has highlighted so many inequities that exist in our system, and it has exacerbated those inequities. So the impacts have fallen disproportionately on people of color. Homeless seniors, we see that they actually age 3 to 4 times faster than their house counterparts. And I actually just did a presentation on elders and homelessness. And there are some, it's horrifying and shocking, a whole other conversation. But part of this, and this is about that intersectionality. For homeless seniors, things are even worse for people of color. Finally, we have what's called a coordinated access system that is the sort of federally defined, the system that we have that puts people on a list to have access to housing in the first place. And it's kind of a holdover, but the system and the process in place for it is not equity-based. And so by using that system, we are making it even harder for people of color and for elders of color to gain access to housing. And so we are getting in the way of even reaching our own goals in that system. So next slide. That is what I alluded to earlier, and that is an aging population. So adults over 50 are the fastest growing segment of the homeless population by age group. And across the US, 30 years ago, 11% of the homeless population was over 50. Now, half of homeless adults are over 50, and of those, almost half are first-time homeless, which is a huge deal. people they have access and mobility issues. They don't know how to navigate a homeless system. It is a very devastating situation for people. People have dementia, so many other issues, and now living outside on our streets and navigating a system that is really difficult to navigate. Next slide. And so I've mentioned some of this. I'll skip through some of this. We can talk about it in the discussion. I'd like to leave as much time as possible for a conversation. And then we have this sort of convoluted landscape. This here is the landscape in Multnomah County, and there we are talking here about, we want to talk about the state of Oregon, and this is here, it's quite likely much more complex than in many other counties, but there is an overlap, and we see a lot of the complexity of the interplay of federal, HUD, state, county, city laws and regulations and the entities involved in housing. So though the picture is different in different counties, there are many similarities. And this is just a list of, and they also are called, there's so many acronyms and they often have the same words in them, so they all sound the same. But I don't want to focus too much right now on Multnomah County. I'll get to that a little bit. But next slide, please. So in Multnomah County, what we did do is recognize that deep need for supportive housing. We need the wraparound services and the deeply affordable housing in order to end chronic homelessness. So the metro region, the 3 counties, Washington County, Clackamas County, and Multnomah County, passed an unprecedented measure, revenue generating, to be able to provide those services. So bonds, we passed a lot of housing bonds, but that's for the brick and mortar. That's not for the services people need to be supported in the housing. And so this is $2.5 billion over 10 years to provide the kinds of services that can end chronic homelessness. And each county has their own implementation plan, local implementation plan, or LIP, that has been created. And the priorities in that are equity, supportive housing, behavioral health services, and there's a priority for alternative shelter, which is different from traditional indoor congregate shelter. It's anything that's like village models, it's sanctioned encampments, it's the safe rest villages you've been hearing about if you're in the Portland area a lot. Next slide. So the reality is, however, that even though we have put so much into expanding housing access, including supportive housing, we have, as I said earlier, about 8,000 people in Multnomah County alone, let alone the region, that will continue to face unmet housing needs. So next slide. So what do? We see this, and I know as healthcare providers, we are particularly attuned to this and the trauma and suffering of people who are living outside because of what we do. And so the way that I have thought about this, because honestly, so everything is politicized these days, but I think about it in a public health capacity. So many of us I know have heard of the concept of harm reduction. So that's an approach used to mitigate the negative impacts of an underlying unhealthy condition or set of circumstances. We often see it applied to substance use disorder and getting people syringes so they're not getting diseases from not getting Hep C or from dirty needles, etc. So we have a whole different question than what is the solution to homelessness here. Right now, given that thousands of people are living in horrific conditions on our streets, I believe the question we need to ask and answer is, how do we reduce the trauma and harm being experienced by people living outside and impacting our community while we're working toward those longer term solutions of, supportive housing, et cetera. So that not only can help keep people safe in the immediate term, help them with stability and their help, but right now, I actually volunteer with Portland Street Medicine. So I go out with the amazing teams of people, a doctor, a nurse, a social worker, often a scribe, and we go out and administer care to people who are living outside in the encampments. And I have to say, many people that we care for and support would not be able to move directly into housing, no matter how much they are supported there. They don't want to be in housing. And so where can we have people go that they feel safe and comfortable so that they can even reduce their stress and trauma enough to be receptive to receiving services and talking about this? And so alternative shelter models have shown success in facilitating transitions to permanent housing. So next slide. And I'm sorry, like this is taking longer than I thought. So questions are the most important. So almost there. The idea of alternative shelter is where I think about this. It's that alternative to the traditional congregate indoor shelter model, particularly important now when we've had to have our capacity in indoor shelter due to physical distancing requirements with COVID. And there are a number of alternative shelter models, both in Multnomah County and across other counties in Oregon. Lane County is doing some great stuff. And so we have self-governed camps. You hear Dignity Village, Hazelnut Grove, or some areas. We have sort of sanctioning encampments where, and there's a photo here on the slide, and that's where these structures are placed. And there are services and people come, with Portland Street Medicine, we go to those sites and they have access to services, and it's much more formalized, much more expensive. And some people don't want that kind of setting. So there are all kinds of potential models. Next slide. And so when we think about what's needed, one of the things that I had proposed for people living outside as a harm reduction model is a continuum of services and supports right now that meet people's basic safety and emergent health and stability needs, where they can go that reduce the harm of them living outside on our streets. And when I talk harm reduction, I also mean for the community at large, because a lot of what we see, it is clearly not safe and healthy for people living in the encampments, but it is not safe or healthy for people walking along the, thank you, Meieran, partially, I'm saying, get Medicaid to cover housing is brilliant, but it is not sufficient to say we are going to get people housing over time. We need to just focus on that as people are literally dying on our streets, and as we are seeing such terrible conditions where people can't go to the bathroom, do not have their garbage. We ask why people have so much garbage around their camp, but I mean, I get my garbage picked up every couple of weeks, and I already have in my house, I have garbage building up. If you are living outside in a tent, what do you do with your waste? So what I proposed is a continuum of small sites, a continuum of a number of options that meet people's need. Scattered small sites, like 10 tents, are structured with basic facilities, so hygiene access, a hand washing station, a shower, garbage pickup, needle canisters, and toilets that people can be and know they're not going to be swept, and literally just be in a place that's safer, healthier, and more humane than living outside on our streets. And I have so many neighbors and neighborhoods where people have said, yes, please. I mean, we're in a different time than it's been before. There's still a lot of the not in my backyard. But the vast majority of people are like, yes, please, we know people are going to be here. Why don't we have it be in a place where we can get them services, where it's contained, et cetera. So that would be a coordinated network, super cheap, super fast. You could set it up across the county. Then have also that availability of some of the sanctioned campsites where people can get the services more structured. It's more, more kind of government involved. But some people want that and like that. You can get some job training, employment services connections, and then keep moving through the system. We could have parking lots where people can park the derelict vehicles or the trailers, et cetera, that they're living in, where they have services provided. So we could do that fast. I proposed, it's a 6-month framework I proposed in Multnomah County, but we could do that fast. We could do it so much more cheaply than a lot of the other options that are out there. And it provides a bridge for people to move up the ladder to get into housing. I saw a really great question in the chat that kind of has gone through. The question is allocating our resources. We have limited resources and we need to allocate amongst those 3 levels. Oh my gosh. Prevention, shelter, and permanent housing. So our questions are about how do we do that allocation? And for me, I feel that we have, with our the new revenue coming in with our supportive housing services measure, we actually have a ton of money in our system. We can do both. And I say we have to do both as we're moving through this. So what's needed? Long-term rent assistance and in-home services, along with coverage by Medicaid and Medicare for prevention to keep people in their house. Housing is healthcare. How many times have we heard that? Shelter, we need to accommodate a variety of needs, and we need case management. We need people to be going in to be those connections, establish relationships so people can move forward. And we need permanent housing that meets a variety of needs. I think that's it. Oh, yes. These are challenges that still exist, and that is that tension of allocating resources between short-term and long-term. We need to do both, and we need to do it smartly. Siloing, we have so much siloing. I wanted to run for office because I thought, okay, we can deal with these policies and then we can work on all this stuff together, and the level of siloing I could never have imagined. And we need to be working seamlessly together to make things work. And we can, I believe we can. We need to actually count who's living outside and understand who it is and have some data and outcome strategies to address, to know where we're going, where we want to be, so we can work toward that effectively. Behavioral health is probably the biggest issue right now outside on our streets, and outreach and coordination. That's it. Okay. Things you can do, and that's it. Get to my final slide with my questions.
Great. Thank you so much, Dr. Meieran. We've had lots of questions run through the chat, and we will do our best to get through all of them. If we don't get through them all, we will certainly follow up with those after the conference as well. So to start us off, Dr. Meieran, you're a part of the Portland Street Medicine Group that helps provide care to those community members who are homeless and or houseless. How is that going, especially in the times of COVID, where our healthcare has seen unprecedented strain, and what efforts are being made to help vaccinate that population, and so forth?
There are a number of, it has been awful. All providers that I talk to who do outreach on the streets have just seen such an escalation of the need, an escalation of the severity of some of the behavioral health issues that we've traditionally seen, but are so so beyond the pale right now. And so we just need more things. I know things feel out of control to a lot of people I hear from as a commissioner, and they feel out of control to me as a provider, seeing people living outside. It is, things are very challenging right now, and there are amazing organizations and people doing this work. And we need more to get resources to people living outside. And a shout out to Representative Lisa Reynolds, Dr. Lisa Reynolds, who's here, who has gone out with me to deliver services and supports to people during the unprecedented heat that we saw over the summer. And vaccines, there are some folks going to, there's not much going to the encampments, but there are groups like Outside In, I believe Central City Concern. There are a lot of groups that will organize stations for people who are houseless to try to get vaccines, but we need to do so much better in that. There's not a way to coordinate. It makes it tough.
Great, thank you. Moving on to another one. How can we as healthcare professionals provide, continued services to those and improve the healthcare system as it is for those unhoused community members that we have? And what organizations can people get involved in to help better serve those people, either through basic medical needs, vaccinations, or just general social services?
It's such a great question. And I mean, the organizations that I see doing so much work are Central City Concern, and I, welcome to, just moving, Dr. Richard Bruno, welcome back. And Outside In, they really get what this population needs. And Barbara Martin, I see you, I see you in there too. They involve peers in a lot of the work they do, people who have lived experience of living outside and the conditions that are experienced, and they're able to understand some of the systems and issues at play. And I think they would be great resources as well.
Great. In terms of the point in time numbers the PIT numbers that you mentioned, are those specifically to Portland or Multnomah County? And are there any statewide estimates at this time?
Yes, those are for Multnomah County. And there are statewide estimates. I don't know those off the top of my head. And hopefully these questions are being collated and I will respond to them, because there are such great questions here. But I see a couple of things specifically about statistics of Portland's unhoused population, maybe with mental health or substance use disorders. And estimates are up to 80% have one or the other or a combination. And so it is really, really high. And I see a note that transient populations can be difficult to accurately count, which is absolutely true. Fortunately, there's a group called Community Solutions, an organization that nationally has a program they call Built for Zero, where they have an approach to engaging the government and organizational efforts to address homelessness and people in the community, but they have an approach to doing a by name count, where we actually have enough people. We have people, it's a lot, but we can actually identify who people are. And it's hard, but there are ways to coordinate those efforts and get the information. And the beauty is, once you have the information, you can track sort of the throughput, who's moving in, who's moving out, where they're going, what we need to be doing, who needs mental health services, who needs employment support, who needs X, Y, or Z.